The talk is on hidden non-allo antibodies induced injury in CABMR patients. May I invite the speaker, Dr. Narayan Prasad. I also invite the chairpersons for this talk, Dr. R.K. Sharma, Dr. Shivendra Singh, and Dr. Himanshu Sharma. Over to the chairpersons.
Good evening, ladies and gentlemen. I would like to thank the organizers, especially Dr. Vivek Kute, and would invite Dr. Narayan for this very important evolving topic. This is like these antibodies are like the hidden component of the Titanic ship colliding, and it becomes much more dangerous if it is chronic exposure, because acute exposure is something which you can treat, but these hidden antibodies producing chronic ABMR, which are both difficult to diagnose and also more difficult to treat. So Dr. Narayan Prasad is Professor and Chief of Nephrology at Sanjay Gandhi PGI, and would invite him for this very important topic, which I think would be very crucial if we want to increase the graft survival much more than what we are able to achieve. Dr. Narayan Prasad, please.
So at the outset, first of all, I would like to thank Professor Sharma sir for this kind introduction and all the blessing throughout my career. And I would also like to thank the organizing committee and the scientific committee of ISOT for this opportunity to talk on this topic, hidden non-allo antibodies mediated injury in chronic antibody mediated rejection. So outline of my presentation would be the non-HLA antibody mediated injury. As we have a lot of talk about the antibody mediated injury, particularly anti-HLA, so I am not going to touch that part. Then hidden non-antibody mediated injury, that is something related to the T cells, and third one part would be the fibroblast per se acts as a immune cells and cause injury, and how this happens. So starting from this study, New England Journal of Medicine study published in 2005, where we can see IgG antibodies targeting the AT1 receptor. This was so important, and a small study on 33 kidney transplant recipients published in NEJM. And they have shown that 16 patients out of 33 had malignant hypertension, and they do not have any anti-HLA antibody. What they have the target IgG antibody against AT1 receptor. And all 16 had the malignant hypertension. And this antibody was of the subclass IgG1 and IgG3. So look at this picture. When you look at this picture, what you see here in the panel A, there was endarteritis. It is a representative slide. Endarteritis. Another one is showing some fibrinoid necrosis kind of the picture. Third panel is showing MRI image with multiple infarct. Here we can see, or the fourth panel, D panel, here we can see those who have the good graft survival, where AT1 receptor antibody negative and anti-HLA positive. And those who have this antibody against AT1 receptor had the worst survival. So that is the something, it is even looking like more dangerous than your anti-HLA antibody. So this was one important information about the non-HLA antibody. Again, what in that study they have shown that you can see the panel A, where a lot of tissue staining is there. When these patients were treated with this losartan, angiotensin II receptor blocker and plasmapheresis, this antibody has been removed. There was total clearing of this tissue staining here. And then we can see here, those who have been treated had very good graft survival as compared to those who do not have been treated. So this was something which was the novel things coming out of at that point of the time. Non-HLA antibody causing graft injury that was treatable condition. So a non-HLA-81 receptor mediated pathway may contribute to refractory vascular rejection, and affected patient might benefit from removal of 81 receptor antibodies or some pharmacologic intervention like simple treatment with losartan. Other important antibodies, non-HLA antibodies which are important, was the anti-endothelial cells antibodies in renal allograft recipient. Here, this was the publication in the Transplantation in 2005 only. And there were 3 case reports were there. Where you can see 2 cases, they need to require the removal of the graft. Graft had been excised. They could not survive this graft. And here we can see anti-endothelial cell antibodies in the Byring titer from 1:10. When they have excised, it went up to 1:80. Only the 1 graft would have been survived. Here we can see they have shown 2 patients who had lost graft after that rescue therapy, including immunoabsorption, mycophenolate with and without tacrolimus. They do not survive. And the titer variation of anti-endothelial antibodies was associated with graft outcome. Here we can see the 4th panel D, lot of the granular deposit. These deposits were actually the anti-endothelial cell antibody deposit on IF study. Other important study which came recently this year in non-HLA antibodies, epitope mismatch in kidney transplant recipient with histological antibody-mediated rejection. This study came in Frontiers Immunology. What they have seen, this was a relatively larger study on 118 patients, 19 patients with a normal histology, 52 patients with ABMR, and 47 patients with the IFTA. Multivariate analysis showed that the pre-transplant HLA donor-specific antibody and 81 receptor antibody were independent predictors of the antibody-mediated rejection and donor-specific antibody. So that was the one information. Again, there was emphasis on the 81 receptor antibody, which is looking like even more important or equally important than non-HLA antibody. HLA antibody. Here, another study came just in pediatric nephrology this year only. What they have shown that DSA negative, they have divided the patients into 2 groups. DSA, donor-specific HLA antibody negative and positive patient. And what they have seen in HLA DSA positive patient, the titer of the 81 receptor antibody, endothelin receptor antibody, MICA antibody, Vimentin IgG and M was relatively higher, but significantly high titer was seen with the 81 receptor antibody and endothelin receptor antibody. So this was another information. And what they have tried to show, when you are taking this 81 receptor, endothelin receptor antibody or MICA antibody, they can give the good separation with the good sensitivity and specificity, good area under curve about the separation from those who are likely to have the antibody-mediated rejection and no antibody-mediated rejection. Other important thing which we have studied, there is something which is wrong going on even with the chronic active antibody-mediated, ongoing antibody-mediated rejection. So what is that? In this study, what we have seen, we have taken the 10 patients with the stable graft function and 32% of the chronic active antibody-mediated rejection. The parameters were almost similar. Other than that was expected that there would be little higher serum creatine value, higher grade of the proteinuria in this group of the patient with CABMR. What was the more important information in this study? What we have seen there that when we have compared the cytotoxic T cells, the frequency was almost normal. But when the cytotoxic T cells, granzyme positive T cells, it was relatively less in CABMR patient and high in SGF, so stable graft function patients. But when you look at here the serum, in serums, granzyme level was very high in CABMR patient. And again, we have seen that the staining for this granzyme was very high in CABMR patient as compared to the stable graft function. And at the gene level, intragraft granzyme, positive levels, intragraft granzyme mRNA level was significantly high in CABMR patient. What does this finding suggest? Probably this granzyme positive cells has secreted granzymes into the serum, and this granzyme went into inside the graft and which caused the injury. And usually, so granzyme is usually secreted from either the side. We have not studied NK cells. That remains limitation of our study. But again, we have seen that this granzyme B cell count was significantly associated with decline in the EGFR, 24-hour proteinuria, and serum creatinine value. So again, it is important to see that despite being the stable graft function and chronic antibody-mediated rejection, no evidences of on BAM's classification about the evidences of the T-cell mediated rejection, despite that the granzyme, which is usually either secreted from NK cells and cytotoxic T cells, was causing injury. So in this study, we have not studied NK cells, but NK cells is again coming up as a major part of the injury, which happens along with the side by side with the antibody-mediated rejections. Other third important part was the fibroblast per se may induce immune-mediated injury. How? There was one study published in 2012 by, here we can see this IL-6 amplifier activation in epithelial region of the bronchi after allogenic lung transplantation. Here they have shown epithelial cells per se start secreting some IL-6, and that cause further IL-6, IL-17 loop activation, and that leads to injury to the graft. What is this IL-6 and IL-17 amplifier loop? Here you can look at this picture. Whenever you have graft inside, any injury happens to the tissue, there is IL-6. IL-6 is secreted. This IL-6 bind to IL-17 cells. This IL-17 and IL-6 all together acts on this fibroblast, and this fibroblast actually is a non-immune cells, but starts acting as a immune cells, and they start secreting some of the chemokines or IL-6, and this comes in the loop. They go on happening, and so this secretion of the IL-6 from the graft again and again, and activation of the IL-6 and IL-17, this loop becomes so dangerous that more extensive injury in the graft. So that is how this IL-6 and IL-17 loops occurs. Coming to this, how this IL-6 is important. Here, whenever you put the graft, endothelial cell activation happens. This endothelial cell activations leads to neutrophilic recruitment that secretes IL-6. And these endothelial cells directly also secrete IL-6. IL-6 bind to IL-6 receptor, and that go and activate this GP130, glycoprotein 130 on the membrane, and Janus kinase pathway is activated, and that secretes monocyte chemoattractant protein MCP1, and that from the acute inflammation it goes into the phase of the chronic inflammation. So IL-6 loop is very important for any injury. IL-17 we all understand is an effector T cells, and here we can see this helps enhance the inflammation, particularly as the effector cells they secrete, and that as we have shown you that in the loop that also activates IL-6, cause inflammation, cause thrombosis. This is well known effector T cells. So based on these principles, we have studied in our own lab that how this IL-6 and IL-17 loops helps in secreting IL-6 in the culture supernatant of the fibroblast derived from renal biopsy of a chronic antibody-mediated rejection patient. So what we have done, we have taken fibroblast from the graft kidney of the CABMR patient, 6 patients, and that were cultured and stimulated with IL-6, IL-17, and combined IL-6 plus IL-17. And then the blockers has also been used. And then we have tried to prove our hypothesis. You can see here all 6 patients, when a culture supernatant was stimulated with IL-6, IL-17, there was similar rise. But when both IL-6 and IL-17 was stimulated, the fibroblast was stimulated with IL-6 plus IL-17, in all 6 patients you can see this IL-6 concentration went many-fold high. So it acts like that when you are combining IL-6 and IL-17, there is enhanced response in IL-6 secretions. Here we can see in the culture supernatant, this CCL2 and CCL20 concentrations also, when we are combining with the IL-6 and IL-17, this levels went up from the culture supernatant. Here we can see the SOX gene acts opposite to this IL-6 and CCL2. CCL2 is basically the MCP1 monocyte chemoattractant protein genes. So here we can see again what to prove the hypothesis. This SOX gene expression usually acts opposite to this IL-6 and IL genes expression. And here we can see this IL-6, CCL2 and CCL20 gene expression was going up when you are treating this with IL-6 and IL-17, but it is going opposite. SOX gene expression was going opposite when you are treating in combined form. But we have further to prove our hypothesis. What we have done, we have again treated with the anti-IL-6 or anti-IL-17. You can see here the tocilizumab, IL-6. Everyone might be knowing now whether tocilizumab has IL-6 property from the COVID time. And then IL-17, and then we have combined this tocilizumab and anti-IL-17. Again, you can see this IL-6 concentration was going down. And this has been proved on the gene level in the form of the mRNA expression for the same, for the IL-6 gene expression and CCL2 gene expression. So conclusion of this experiment was that this study establishes the relationship between IL-6 amplifier loop and chronic inflammation in patients with the CABMR, which are the major cause of the graft loss in renal transplant recipient. The IL-6 amplifier and activation of fibroblast could be an important determinant for transplant rejection, including chronic rejection response, not only in mouse, but also in humans. And inhibition of loop may be helpful tool in modifying the treatment decision and prolonging the graft life. The other emerging concept of the non-HLA antibodies that we all know, ischemia reperfusion injury is very common. Whenever there is ischemia reperfusion injury happens, autoantigen exposure happens. And this autoantigen exposures like the autoantibody, like the anti-LG3, anti-AT1R receptor, anti-apoptotic cells receptor that comes into the picture. Sometimes they cause complement activation, leukocyte infiltration, and the graft injury. Here we can see what is this anti-LG3. Release of LG3, the fragment of the perlecan, a large proteoglycan protein that is usually seen in the basement membrane of the vascular cells or sometimes in the tubular basement membrane also. So whenever there is ischemia reperfusion injury, there is the exposure of these antigens that comes into the picture. Antibody agents that may cause the graft or vascular endothelial injury, macrovascular injury. Here we can see that vascular endothelial apoptosis happening that cause the release of the apoptotic exome-like vesicles. Again, there is autoantibody production like anti-LG and ANA. And these antibodies may produce acute injury or may produce long-term injury, resulting into sometimes the transplant glomerulopathy. So these are few important things coming up in the field of the transplantation. And now probably the anti-IL-6 has been tried in many, and there is an ongoing trial about the anti-IL-6 tocilizumab in treatment of the CABMR patient. So take home message from this presentation is that non-HLA antibodies may also mediate severe graft injuries and graft failure. Other than immune cells, fibroblast cells in the milieu of inflammation may induce injury in the graft. IL-6, IL-17 amplifier loop may be the new target to combat the injuries in case of the CABMR. So thank you, ladies and gentlemen. Thank you for your kind attention. Thank you, Chairman, and thank you, everyone.
Yeah, thank you, Dr. Narayan. I think it's a very excellent presentation. And the take-home message is that we have to slowly and surely move from the present management and also evaluation of these patients who have chronic rejection or even acute rejection, where the management is very broad, using drugs which are acting on so many epitopes and so many directions, also harming the patient itself. to a direction where we can become much more specific. We can take a clue for cancer management where the therapy has become much more specific and effective. I would invite Dr. Shivendra and Dr. Himanshu, if they have, you can unmute yourself if you have any questions or inputs. I think it's a very important area and hopefully to change the direction of management of chronic ABMR.
Yeah, thank you, sir. I think the talk was really excellent, and knowledge about non-HLA antibody-mediated graft injury, its importance has been highlighted. Question is, sir, what will prompt to work up on this line if we are suspecting any chronic antibody-mediated rejection? When we should think on this line,
thank you.
Besides traditional.
Yeah. Thank you, Dr. Shivendra. Actually, really a very important and pertinent question needed to the practice. So whenever many times we see that there is a graft dysfunction, but you are not able to find out any common reasons for that. Like the anti-HLA antibody, you are not finding that the patient was that high risk. There were no preformed donor-specific antibody. There is no de novo any anti-HLA antibody, but the graft function is going on. When you do biopsy, you will not see any signs of any other injuries like severe rejection. And even if the rejections are, sometimes rejections are there, but you do not have correct explanation for that. In that scenario, we must think of something other than this common thing, anti-HLA antibody, something else is happening on, like the anti-T cell receptor antibody, anti-endothelial cell receptor antibody, or sometimes when the chronicity is already going on, then it is possible that this IL-6, IL-17 loop is activated. And now the fibroblast per se is causing that much of the injury. So blocking this with the use of the tocilizumab or anti-IL-17, that might be helpful. And one report came for this different tracheal transplantation that was showing very much promising result for this chronic, halting this chronic injury. So it is possible that this might be the future treatment for the patient of the chronic antibody-mediated rejection. I hope so, but definitely we do not have that much of a clinical strong evidences at present.
Yeah, I think it's an evolving area.
Yes,
Shivendra is making the point is correct, but you have to be open and broad-minded so that we move a more specific management and also the diagnosis. Because at present the diagnosis is basically if you find the antibody which is HLA specific, if you don't find, you are actually moving in dark because there are so many other antibodies which could be there. But it's the right direction to go if we want to change the outcome now. So Himanshu, if you have any point, any input or question?
Thank you, sir. Thank you, sir, for such a nice talk. This is a very important topic in terms of non-HLA antibodies, because as a nephrologist, when we have a rejection in a patient or in a transplant patient, and we don't find anything normal, like a normal antibody rejection or some normal cause of rejection, in that condition, these antibodies, considering these antibodies, will be a very, very much important. And in coming time, we will expect we will have a more of information available on these non-HLA antibodies so that we can manage the patient in a better way.
Okay.
And thank you, sir, for such a brief and crisp information on this topic.
Thank you very much.
So thank you very much, Dr. Narayan, for this excellent presentation. And I hope everybody enjoyed the talk. At least I really enjoyed it. So we will hand over now to the organizers for the final words. Thank you very much.
Thank you, sir.
Thank you, sir.
Thank you, sir. Thank you very much. Thank you, sir.
Thank you, the speakers and the chairpersons.